A very good afternoon to everyone. Doc Plexus brings you an exclusive telecast of one of its kind surgical workshops between 2021-2022. This was performed in association with AIMS and Foundation for Obesity Research and Metabolic Surgery. As you know, in our previous session, we heard Dr. Sandeep Agarwal talk about overview of obesity and bariatric surgery. So for today, following up, we have Dr. Amardeep Kumar, who's going to talk about patient counseling and perioperative procedure. He's a fellow in bariatric surgery at the Department of Surgical Disciplines, AIMS, New Delhi. So over to you, sir. Please begin today's session.
Good afternoon, my friend. My topic for the discussion is patient counseling and preoperative workup. In 1948, World Health Organization recognized obesity as a disease. As Sandeep sir has told, obesity is associated with lots of comorbidities, starting from the diabetes, hypertension, vascular disease, gastroesophageal reflux disease, obstructive sleep apnea. There are many more. So we can say obesity is like a harbinger of disease. So obesity is measured through the many of the parameters like anthropometric and non-anthropometric parameters. Among the anthropometric parameters are the body mass index, skin fold thickness, and waist circumference, waist hip ratio. Among the non-anthropometric parameters are the densitometry, measurement of fat through CT and MRI. But the most commonly used parameters are the body mass index, which is most commonly used to define the obesity. According to the World Health Organization, the classification of obesity is defined as the class 1 obesity is the BMI is more than 30 up to 34.9. Class 2 obesity is the BMI 35 and up to 39.9. And class 3 obesity is BMI more than 40. It is also known as severe obesity or morbid obesity. The indication and the patients already has been discussed by the Sandeep sir, so I am just omitting this slide. This is the criteria for Asian selections. We are slightly we keep the cutoff lower for the selection of Asian patient, because in Asian populations there are a lot of fat. This is mainly located on the abdomen, so we called as a central obesity, and the central obesity are like more pathological. So the criteria is cut down lower for the Asian populations. So coming to the contraindication of bariatric surgery, there are some known contraindications, like if the patients are taking some having the active substance abuse disorder, having the active psychiatric disorder, and the patient have limited intellectual capacity. This group of patients should be deferred for bariatric surgery, because this group of patients would not able to follow the post-operative advice, and this group of patients will landed into the complication and problem. And if there is a like contraindication to the general, it is obvious, and especially in the pregnancy and the female anticipating pregnancy within an year. So this group of patients should be deferred, because there are nutrition concern, because after bariatric surgery there are a lot of malabsorptions occurs, and generally the requirements of nutrition and minerals increases during the pregnancy. So there may be bad outcomes over the on the fetus, so it should be deferred. And if there is cirrhosis with the portal hypertension, especially child grade 2 and grade 3, this group of patients should be optimized before consideration for the surgery. So coming to the bariatric team is unlike the other departments. The bariatric team involves the a multidisciplinary team approach. This team, the core member of this team was formed by the bariatric surgeon and his team, anesthesia and his team, bariatric nurse and bariatric physician, nutritionist. These are the core member. Other associated member that require the participation of the psychologist, endocrinologist, cardiologist, pulmonologist, and gastroenterologist, because there are a lot of comorbidities that need to be addressed before surgery, and patient taken only after the optimizations by the concerned department. So coming to the patient counseling part. So why counseling is the purpose of counseling is to set the realistic goals. So patient think that after bariatric they are going to be almost normal, but so their expectations are different. So we have to make them aware what they will achieve after bariatric surgery, and also the part of counseling to identify the risk factor, to assess the compliance level of the patient, to follow the our advice after bariatric surgery, and their motivation level, how they are motivated for this surgery. And since the bariatric surgery causes a lot of behavioral changes in the diet, and that required a lifelong follow-up to for the nutritional assessment and for other concern. So these things need to be discussed with the patient. So, patient counseling is the key tool for the better patient outcome, and the purpose to make them understand the whole bariatric process. So, apart from the patient, the family member and caretaker should be involved in the for the bariatric for the patient counseling, and as well as educating the patients about the all about the bariatric surgery and the procedures and regarding the complications. So the counseling should be done by the separately by the surgeon, dietitian, and psychologist. The role of surgeon is to discuss about the different surgical options available, their benefits, and related complications they might happen. So also need to be discussed about the perioperative process, need of preoperative optimization, about the dietary modification that is required prior to surgery and also after the surgery. And patient need to be like after losing weight, there is a real challenges arises to the patient to maintain that weight. So it is important to follow lifelong the dietary intervention, dietary advice, as well as the patient need to be like physically active. And since bariatric surgery consists of malabsorptive procedure, so there is a need of bariatric supplement in the form of multivitamins, proteins need to be taken by the patient up in the post-operative course, and they need to be followed lifelong. So the role dietitian is the mainstay of bariatric program. So the role of dietitian is to make them understand about the food energy dynamics, and patient if they are patient before planning to the bariatric surgery, patient should be started on the preoperative diet plan, like very low calorie diet plan. And the role of dietitian is also to discuss about the post-operative diet changes, various phases, like after surgery we start on the liquid diet, then we switch to the paste like that, then after that we allow the semi-solid diet, that we will discuss by our dietitian in detail. And also to discuss discussion about the what are the do's and don't about the diet. So, counseling by the psychologist, the role of psychologist to assess the mental state of the patient, because the most of the WAGE patients having the component of some depression, anxiety disorder, and there is some behavioral issue, they need to be cited out and need to be addressed. And also to check for the compliance and motivation level of the patients, and to assess the support system, because it has been seen that if the patients having a good support system in the form of friend and family, they have get the better result, and they land up into the complications. So behavioral issues like eating disorder and sedentary lifestyle need to be addressed before planning of surgery. And after post surgery, the patient has to go through the lifestyle changes and behavioral changes that need to be discussed in detail by the psychologist. Coming to the history taking part, so the history taking is start with the basic preliminary details. We record the some anthropometric parameters like weight, height, BMI. Patient has to be asked for the progression of weight gain, because the weight gain could be of patient has regained weight in the short term basis or maybe in the long term basis, that need to be especially asked. And if the patient has already taken the any weight loss attempt, either it could be like supervised or unsupervised, and also assess the activity level. So eating disorder is very common in the bariatric obese group of patients. Its incidence lies about around 30%. And binging, purging, grazing, night eating, this type of abnormal eating behavior has seen in this group of patients. So already I have told the comorbidity related to obesity there are a number of comorbidities. So each comorbidity need to be especially asked from the patients, and what treatment they are getting for that medical problem should be noted down. And according to that, because this comorbidity we help us in deciding which procedure we are going to offer that patient. And in the personal history, specifically, patient should ask for about is there, are they a smoker or they are alcohol drinker or not, because if they are taking alcohol regularly, they should abstain the alcohol, because the taking alcohol is the relative contraindication. And continuing smoking, at least we want at least patient to stop smoking at least 2 weeks prior to the surgery, because in this smoker it has been seen that the smoking causes a lot of complications, especially in the like bypass cases. We got there is increased chances of marginal ulcer. So other point, the history about the family should be asked if there is a like familial tendency of obesity or not. So this is the long list of the causes that causes secondary, that is the secondary cause of obesity. Few hours, the secondary cause could be due to hypothyroidism, Cushing syndrome, hypothalamic obesity, yeah, female taking oral contraceptive pills, pregnancy. Yeah, some patient is on some medications like for antidepressant, tricyclic antidepressant, that causes the weight gain. So this particular secondary causes of obesity should be searched for, but unfortunately, this represent only minority of obese cases. And you will get the short history of weight gain, and this secondary cause is totally reversible when we address that. When we find out what is the reason behind that. Coming to the physical examinations, the neck measurement of neck circumference is important. It is indicative of if the neck circumference is more than 40 centimeters, indicative of the patient may have component of obstructive sleep apnea. And waist hip already talk. We can like determine about the which type of obesity patient is suffering from. Either it could be like central or peripheral. Limbs should be assessed for edema and varicosities. And on abdominal examination, we have to search for the previous scar, ventral hernia, and sign of any venous hypertension. So this is the battery of long list of pre-operative workup investigation. Apart from the blood routine hemogram, we advise patient, we assess patient for advising for the bone profile, coagulation profile, diabetic profile, lipid and thyroid profile. And especially in this bariatric patient, generally they suffer from some nutritional issue. Also, the chances of nutritional issue raises after surgery. So the common nutritional problem encountered in such group of patients is between B12 deficiency, folate deficiency, between D3 and iron profile. So this would be checked before surgery. And under the radiological investigations, the ultrasound should be done to assess the conditions of liver, because there are high incidence of non-alcoholic fatty liver disease. It around more than 50% you will find in the morbidly obese group of patients. And also to rule out any component of portal hypertension. And there is there is increased frequency of gallstone disease when compared with the normal general population. That should be checked for. Under the cardiac, we should have to advise for ECG and 2D echo. Respiratory evaluation should be done through PFT and sleep study. Sleep study is generally not done, but on the case-to-case basis, we can advise the patient. Sleep study is an important part, because most of the patient have some degree of obstructive sleep apnea component. In the gastrointestinal evaluation, we evaluate through upper GI endoscopy and fibroscan. Fibroscan is the measure of liver stiffness, is also measure the component of how much cirrhosis is present. So the evaluation of cardiovascular system, we know that diabetes, hypertension, dyslipidemia, and OSA increases is the significant risk factor for the cardiovascular disease. And in the obese population, there is increase in the sympathetic tone, feeling pressure, workload, that increases the risk of myocardial infarction, ischemic heart disease, and sudden cardiac death. So a detailed medical history and family history is important regarding the cardiovascular system. And if needed, stress tests and coronary angiography should be done on case-to-case basis. Evaluation of respiratory system, the physiological changes occurred in the obese individuals are there are decreased compliance of chest wall and the lung parenchyma, as well as increased bronchial vascular resistance that causes a reduction in the gas exchange and the mismatch of ventilation perfusion ratio. the two most important problem we need to discuss regarding this. One is the obstructive sleep apnea. Second is obesity related malignant hypoventilation syndrome. The incidence of obesity obstructive sleep apnea is around 74% in moderately obese patient, and if untreated, that lead to hypoxemia and hypercarbia, further into pulmonary hypertension and pre-state cardiac arrhythmia. And even and also in during the anesthesia, when the narcotic medicine has been given, they blunt the protective arousal of the hypoxic patient, and they may lead to the profound hypoxia and respiratory arrest. So, for definition of obesity-related malignant hypoventilation syndrome is when PuCOT is more than 45 and the oxygen saturation is less than 94 without oxygen supplementation. This condition increases the risk of prolonged intubation, tracheostomy, and death. So, extent of probable events should be assessed in detail. Evaluation of upper GI system, generally it has been seen that on upper GI endoscopy, the chances of abnormal finding is found to be around 10%. So it is important to, if in endoscopy there is infection by the H. pylori, it need to be eradicated, because H. pylori infection is a risk factor for gastric malignancy. And in some group of patients, if there is family history of gastrointestinal neoplasm, there a routine endoscopy should be advised for such group of patient. And upper GI endoscopy also give the opportunity to detect hiatal hernia. There is a high incidence of hiatal hernia in this obese group of patient, around 33%, that alter the choice of surgery in the decision making. In the bypass procedure, generally we resect the stomach. The remnant stomach become inaccessible. So it is a good idea to see inside of the stomach before planning bariatric surgery. Coming to the perioperative, that will be discussed by our dietitians. In roughly, generally we advise 2 week, at least 2 week of 1 to 2 week of preoperative very low calorie diet. The purpose of this BLCD diet, we want patient to lose around 5 to 6 kg of weight, because by losing such weight, that reduces shrink the liver, and that makes we will get the more area to operate in the upper part of abdomen, and also it increases the overall physiological compliance of the patient. And lastly, we want to discuss about the consent form. Generally, I advise you to take the umbrella consent, mentioning all the 3 primary procedure, because many times if you are like planning for the malabsorption procedure and during intraoperative we found the liver to be cirrhotic, then you might require to change the type of procedure. You might require to like bypass, you convert the bypass, go for sleep gastrectomy. And high risk consent should be taken, especially if after pre-operative optimization, if anesthesia people say there is a risk of ICU stay or prolonged. In such cases, high risk consent should be taken. Generally not required. So I would like to conclude my topic that bariatric surgery is a team approach, and patients will be taken for surgery after detailed clinical history, thorough clinical evaluation, adequate preoperative workup, and optimization. Stabilizing such a team is the key to the success, and preoperative weight loss should be strongly encouraged. Thank you very much.
For nicely covered preoperative workup of bariatric patients. For the benefit of the audience, could you just elaborate on how the comorbidities will affect the choice of the procedure?
Yeah. Thanks, Dr. Aditya, for asking this question. So definitely, generally, it has been seen that there are 3 primary procedures: bypass, Roux-en-Y gastric bypass, sleeve gastrectomy, and the mini gastric bypass. So the sleeve is the restrictive, and other 2 are the more malabsorptive than obstructive. It has been seen that in initial reports that in the metabolic, if the patient with obesity having metabolic component like diabetes, hypertension, dyslipidemia, then in such group of patient, the like bypass procedure holds good for the resolutions of this comorbidity. Secondly, if patient has cirrhosis, then obviously the bypass procedure will may precede the liver failure. So in this situation, sleep would be the good options. And in the extreme of ages, especially elderly patient, we are expecting the survival could be like around 10 years, 15 years. So it is better to go for simplest procedure, that is a sleeve one. And there are a lot of criteria to like choose. If the patient having the super obesity, like BMI more than 50, then we want to aid a more morbid procedure like mini gastric bypass. Our preference remains in such cases. So there are many criteria. Even in if patient having like GI anomaly, we like some dextro torsion of intestine if you don't know where the intestine is going. So in this case, it is advisable not to do any bypass procedure. Is to do the simpler sleep procedure. Thank you.
Just to add that GERD is a very important body selection.
Yes.
Patient has severe acidity or erosive esophagitis or endoscopy. We prefer to do a bypass. So that's not to add to what.
Yeah. Thank you, sir.
A colleague recently asked me, how do you assess whether a patient is motivated for bariatric surgery? So do you take that question?
We can check that's why there is we advise patient to follow the preoperative BLCD diet. There is one way. If the patient, we advise to for the weight reduction, if patient is rigorously following the BLCD diet therapy strictly for the 2 week, it means patient is showing they are showing motivations. Obviously they are serious about bariatric surgery. And other things, obviously, if the patient is compliance is good, if compliance is good, then we can consider patient is motivated.
Compliance, you can assess compliance only when the patient comes to you multiple times.
I think the first one is that was actually very, very important. That patient has lost some weight before surgery on BLCD. That's the strongest indicator is motivation. And the another thing which I ask when the patient comes, are you coming yourself or are you being pushed by your relatives or friends?
So I always ask the patient, have you come on your own that you want the surgery, or your father or wife or is pushing you for surgery? Because then it's a totally different situation. So that's again a stronger indicator the patient is motivated. I think surgeon is the best assessor. Besides obviously a formal dietary and psychological evaluation, by experience you can make out after, and you need to spend time with the patient. It's not that you quickly note down and do like a checklist. You have to talk to the patient, show empathy, avoid body shaming. Even if the patient doesn't want surgery, respective views. And that's, you are the best person to assess how motivated the patient is besides these things. So I would say with experience it comes, you can assess it.
Thank you so much, Dr. Kumar, for your insights on this topic. It was a pleasure listening to you. Dear viewers, hope you liked today's session. Stay tuned for upcoming parts of the surgical workshop. And do send us if you have any more questions or queries for the panel. I would like to thank AIMS and FORMS for arranging such surgically lit sessions with our community of doctors who would highly benefit from the same. So thank you for watching and have a great evening ahead. Thank you so much.